Yeah, so again, a combination therapy talk by respected Dr. A. Ramchandran. Again, we have one of the excellent speakers, Dr. Hemant Thaker from the Mumbai, and he's a founder member for pre-MCBC's International Forum, the founding chairman of South Bombay Physician Club. He has presented cases and numerous posters at World Conference like ED, AAC, World Conference of Hypertension, and he has innumerable publications in desk journals and has contributed many chapters to the API textbook of postgraduate medicine. In 2014, he was awarded the Giants International Award for his outstanding contributions to society. So the polling question is here. How do you choose your add-on therapy after metformin in type 2 diabetes patients? So over to you, sir.
I need to share my screen.
For Hemant sir's session, do you think we require different target therapies for the elderly and the young? Yes and no. Can I request the AV team to put up the polling thing now, please?
Hemant, give us 2 minutes. Let the poll finish and then you start.
Sure. No problem.
Can we have the slide on the question coming up?
Rohitji from the AV team, can I request you to put that polling question right now?
Yeah, it's come up. Thank you, Dhruvi.
Thank you. We would request all the audience to make a poll. Do you think we require different target therapies in the elderly and the young? I think we'll discuss the results when Dr. Hemant sir has finished his talk. I'll stop sharing Hemant sir, and I request you to please share your slides now, sir.
Okay.
Just put enable editing up, Hemant, otherwise it will not.
Yeah.
Have you got the screen?
Yeah, we got the screen.
All right. So good afternoon, everybody. I think I am almost into the post-eclipse phase. And I want to be a little poetic because the eclipse has taken away all the COVID and all the muck with it. We are only left with a little bit to go. So we are looking for a good trail for the elderly to follow. And once the elders make the trail, obviously it will become a track for the young. And taking on those lines, I want to talk about type 2 diabetes management. And this is an extremely important thing where age is the key consideration. Now we can keep talking and debating. Even the nation will want to know when they debate what is old and what is young. But I'm going to now, for today's presentation, say that the young diabetic is the one which is between 35 and 50, maybe under 35, because there is no universally accepted definition. And for the relatively younger population, like I said, under 50, it is for the more than 65 that I call elderly. And do we need two separate approaches for these two groups? What would be some key treatment consideration for the two age groups? So we've always looked at diabetes about being cardiocentric, metabolic centric, weight centric, side effect, pleiotrophy, but now we are looking at some other treatment considerations depending on age. And some of the treatment related considerations in an elderly diabetic is that advanced diabetes has a lot of pathophysiologies for which the same drugs may not work for different reasons. There are lifestyle issues. There's forgetfulness, lack of care, resource limitation, education, etc. And obviously, with the micro and the macrovascular complications having stacked up, they explode into renal or cardiovascular diseases. And there is a higher chance of adverse effects or even tolerability issues. So type 2 diabetes is unique in the elderly because older patients with diabetes are at higher risk than those without diabetes, especially when they have cancer, vascular deaths, functional disability, geriatric syndromes, including depression. They have falls, fractures, they have cognitive impairment. So the key tolerability issues and considerations in the elderly is polypharmacy. The whole tray is full of different colored pills and concoctions. This leads to drug metabolism and elimination, which may be deranged, especially because he may be having early or full-blown CKD. Then there is forgetfulness. I don't want to label it as Alzheimer's, but there's lack of care. There's multi-morbidity, there's autonomic neuropathy, a great amount of hypoglycemia because they depend on others for their food, secondary infection, falls giving because of osteoporosis, and obviously age-related malignancies. There's so many other things that it become a prose essay. I don't want to get into that. So how do we deal with it? We prevent the dangerous effects of polypharmacy in elderly patients because we know that almost 45% of women and 58 of men and 58% of women over 65 take 5+ medications weekly, and 12% take 10+ medications. 43% of elderly ambulatory, and so on and so forth. So these 70-80% of aged care facility residents are willing to discontinue medication. And this polypharmacy leads to adverse drug reactions. They have adverse reactions at home, in the hospital, wherever they are cared for, and this can seriously impact the elderly patient's health. Again, the problem is they are predisposed to the risks associated with polypharmacy. So much for polypharmacy. If you look at diabetes, oral anti-diabetics and drug interaction, if you look at the different groups, metformin fortunately is not metabolized, but the sulfonylureas have extensive hepatic metabolism. TZDs also liver. SGLT2s metabolize mostly in the liver, but they have renal excretion. The gliptins, CETA is not appreciably metabolized, but VILDA is predominantly in the liver, so is SAXA, and LINA has a dual route. So it is only metformin and sitagliptin, which is minimally metabolized or excreted through the hepatobiliary system. The others, if you see CETA, VILDA, EMPA, DAPA, of which my previous two speakers discussed everything, there is no clinically relevant drug-drug interaction. So what causes polypharmacy? Different clinicians and their patients have different opinions on treatment. We've already discussed the age-related issues. Then there is the counseling and the follow-up problem. And of course, the trust issue. In India, we go to as many doctors as we go to shops when we go looking around for what we want. So we have to have joint decisions. We have to have special care. We have to have safety first, and we have to build trust. It is on these 4 building blocks that you have to treat elderly geriatric patients. So the tips for reducing the harmful effects is to ask the patient to bring all the drugs that they are taking, including OTC, supplemental, herbal. Screen for unnecessary drugs and throw them out so he or she is not burdened. Prescribe drugs with less, simplify the drug regime. Also, do not keep changing the regime time and again. And if that is done, you will find that their issues will be sorted out. I think there was a poll thing, and that's not allowing me to move. A poll came in. Yeah. So thoroughly explain the prescribed regimen to ensure patients understand everything. And please give written instructions. And this is in hard copy because elderly patients are not very swanky to understand soft copy prescriptions. Even in the lockdown, we've had a tough time giving soft prescriptions. We have to double space them and enlarge everything. So age and efficacy, remember, there are the physiological problems. With increasing age and advancing diabetes, there's a gradual but steady reduction of EGFR. There's also a reduction of active beta cell mass. When the EGFR goes down, the efficacy of the SGLT2 gets reduced. And with dwindling beta cell mass, the role of sulfonylureas, the pet tablet amongst Indians, is questionable. If you look at sitagliptin, the efficacy in age independent, SGLT2 efficacy may reduce with increasing age. You can see these two groups which tell you clearly canagliflozin in the elderly versus sitagliptin in the elderly. And you can see how the efficacy dwindles with age. All patients under 65, more than 65. With Sita, they have stretched it to all patients, mean age 72, under 75, and more than 75. The arrow is straight and flat, green in color, but the arrow dips with canagliflozin. Efficacy reduces as age progresses with SGLT2s. If you ask me why, the answer is very simple. The longer the duration of type 2 diabetes, the gradual erosion in EGFR, microvascular complications. And you can see as the duration of diabetes has increased, the red arrow has shown you the lower EGFR. So GFR declines steadily with aging. No matter how well controlled the population is, as far as diabetes is also concerned, there is an age-related erosion, and therefore that has to be accepted. Common age-related tolerability issues with the different OADs. If you see metformin, may have GI irritation, sulfonylureas, hypo and hypo unawareness, TZDs, we know everything from edema to fractures. Dr. Ramachandran clearly talked about SGLT2s, urinary tract infections, volume disorders, and hypotension. But gliptins, till now, we have no specific age-related tolerability issue. And when you focus on hypoglycemia in the elderly, remember it is more difficult to recognize because symptoms are non-specific, misdiagnosed, misinterpreted. They have an atypical presentation. They have little warning or unawareness of autonomic symptoms. And patients with dementia are unable to communicate their problems. Plus the hypoglycemia in the elderly, there is an interplay of risk factors. There's malnutrition, comorbidities, old age, acute illness, hospitalization, heart failure, insulin or sulfonylurea therapy, polypharmacy, blunted counter-regulatory responses, home care, social isolation, lots of problems. So this is an important study to show you that sitagliptin plus insulin gives not only better glycemic control, but less hypoglycemia than insulin alone. One would have thought insulin would give the best glycemic control. But when you combine Sita with insulin, not only did you have good control, as you can see in the left slide, but you also had less hypoglycemia, with blue being sitagliptin and the other one is the placebo. So that is something which is important. If you look at the CVOTs, TCOS, which is the one with sitagliptin, showed that with old age, all the CVOTs showed worse overall outcomes. But if you see the observation from TCOS, where they compared the event rates in the elderly versus the rest, while the old age was associated with a significantly higher event rate of hospitalization for heart failure or death, all-cause mortality, malignancy, severe hypoglycemia, and fracture, the primary and secondary CV composite was also significantly higher in such patients. In the TCOS elderly publication, there was no worsening of outcomes in the elderly. So if you see the routine CVOTs versus TCOS, in the elderly population, use of sitagliptin was not associated with further worsening of MACE 3-point or 4-point or HHF death all-cause mortality, and the glycemic benefit of sitagliptin, remember, was nullified in this study. So glycemic equipoise was met with. TCOS was an eye-opener, especially for the elderly people. If you look at the real world, in the real world, no increased risk of CV events in older subjects. Initiating DPP-4 versus sulfonylurea. You can see sulfonylurea versus DPP-4 in the graph, sulfonylurea in red, DPP-4 in blue, composite outcomes, MI and stroke. And this is very clearly seen that the gliptins were associated with a lower incidence of non-fatal MI, stroke, and death in both elderly patients with or without history of CVD. The fracture risk associated with the common medications used in treatment, you can see the comparative fracture risk. Look at the values till you come to the bottom. The DPP-4 inhibitor value adjusted is very, very little as compared to TZDs, SGLT2s, and GLP-1 agonists. I have highlighted each of them in the red box so you can see that. What about sarcopenia? Anyway, age causes sarcopenia. So is there any correlation between elderly type 2 diabetic sarcopenia and their safety of gliptins? So this was a study which is an observational thing which they collected from patients. And the conclusions were that the present study emphasized that DPP-4 therapy in elderly diabetics leads to better glycemic and inflammatory control and is also associated with better sarcopenic parameters, preservation of lean body mass and strength and physical performance indices. Now, people will wonder why we are looking into such fine and tiny things. But at 65 plus or at 70, every little fragment of strength, of physical performance and body mass is very important to the diabetic because he wants to trudge and move into the next decade happily. Gliptins, there is an improvement in cognitive function in elderly patients with or even without Alzheimer's. So they did a mini mental state examination, what is called as MMSE, in 250 odd patients. And they found that patients with or without, there was significant improvement in patients with Alzheimer's disease in MMSE scores as compared to the patients receiving metformin. So this was a study of MMSE scores in two groups, one receiving SITA and the other receiving metformin. So overall, if you see, there's better treatment adherence than conventional alternatives. And you can see the bar graph here, which tells you how people discontinued, how people switched, where augmentation was required and where things were discontinued. And if you see the second bar, it's very satisfactory as compared to the others, because the second bar shows the pale blue remained on index drug class with no augmentation. So gliptins were associated with better treatment maintenance and lower discontinuation as compared to SUs or TZDs. So in the elderly, the treatment considerations are clear. It's an advanced stage of disease. You need proper drug selection that can address the pathophysiology. It may be difficult for such patients to adhere to lifestyle modifications. There is so much polypharmacy, you have to simplify regimens. You have to look at the age, the comorbidities, and you have to understand that self-medication, sometimes often without family support, is the order of the day. And you have to thus strike a balance between efficacy, sustainability, and tolerance to make your goals clear to the other accompanying family members and the patient. Having finished the seniors first, we now come to the juniors. It's like the upper house and the lower house. So the relatively young diabetics between 30 and 50, are they going to follow the trail laid down by the seniors and make it a trek? They also are a population with special needs. They have a long life ahead of them with a lot of responsibilities. They have a workload of modern times because they are the economic firepower. Difficult to follow a healthy lifestyle, you're asking me. They live in the moment. Even in lockdown, they want to live. And thus the prevalence of diabetes is steadily increasing. In India, diabetes is at a lower age. Diabetes in young, what are the treatment considerations? Early, effective, and well-tolerated management strategy, which should focus on very long-term durable control. No short-term approach. It's not for a decade and a half. It's for 3.5 decades. Focus on lifestyle modification. You've got to kick his butt so that he kicks his feet and muscles into action. You have to educate him. You have to show the sustainability of therapy. You have to address all the key pathophysiologic points. Ominous octet. Focus on prevention of short and long-term complications. So the management strategy should affect the work life, the style, minimally as possible, because that's his bread and butter. And unless you don't know his job or work pattern, you can't tailor his medication. Now, this is a very lovely, little busy slide, but it shows the 5 stages in the progression of diabetes, each of which is marked by important changes in cell mass, phenotype, and function. Although conventionally diabetes is thought to be a continuum, this slide has been made because it shows its important characteristics. If you look at the beta cell mass of a patient, from stage of compensation to stable adaptation to unstable early decompensation. And in that, you can say, may not be associated with noticeable symptoms. So 1, 2, and 3 is the prevention phase, where you don't know, the patient doesn't know. Since he doesn't know, he doesn't come. He probably comes in stage 3. And therefore, the yellow arrow, horizontal one, which says manage, spans a little bit into stage 3, which is stable decompensation, unambiguous expression of diabetes mellitus. When he comes, there is still enough insulin secretion to prevent progression to ketoacidosis. More than 50% of the beta cell mass is gone at this manageable state. And the last is the stage of complete resistance, severe decompensation. There's all beta cell loss almost gone. Glucose levels are more than 350. You see it typically in type 1 diabetes. You can see it in patients with pancreatitis, and rarely in typical type 2 diabetes unless they come in a stress crisis. So this is the progression of diabetes pathophysiologies. And as diabetes develops, we currently waste the first 10 years of the natural history. Now, if you look at a gliptin plus metformin combination, it may address most of the core pathophysiologies of diabetes mellitus. If you see, metformin reduces hepatic glucose output, moderate effect on insulin peripheral resistance, and insulin resistance improvement in sensitivity with increase in GLP-1 secretion. DPP-4, its ally, has increased insulin synthesis, increased insulin secretion, and a reduced hepatic glucose output, mild effect on resistance of insulin, moderate effect on hepatic resistance. It reduces glucagon secretion and helps in GLP-1 GIP stabilization. So the two married together produces an efficacy which is comparable to other agents. And if you see metformin, sulfonylurea, pioglitazone, and voglibose, and if you see over 52 weeks, the SGLT2, where both CANA and EMPA have been described in the bar diagrams. And if you see the gliptins, even amongst the gliptin themselves, which is amongst its own class, and rubbing shoulders with the other agents, sitagliptin shows durable, persistent, and generic efficacy. It is well documented durability either in mono or in combination. It's the only gliptin metformin combo with a 7-year durability data, and is the only gliptin with a 4-year monotherapy data. So mono and duo, both, it was effective in lowering HbA1c, it was durable, and it was safe. So a regimen that lets them carry on with their work. These are the regimens which do not affect their work, that affect specific lifestyles. A drug which can be done in the elderly population who do not go to work. Changes are more difficult where the work demands the type of lifestyle, and a regimen with minimal hazards. If you see the hazards of the others, sulfonylureas, TZDs, and their other combinations, from hypoglycemia to weight gain to GI disturbance to genital mycotic infections to GI disturbances. Sitagliptin requires less frequent monitoring. Ideal monitoring is different for every person, from 5 times daily to once in 3 months to once in 6 months. Monitoring is essential, because if you don't monitor, you can't ensure adherence and control and look for adverse effects. So if HbA1c monitoring is your recommendation, at least 2 times a year in which treatment goals have to be met. Point of care testing for A1C provides the opportunity for more timely changes in treatment. You can see SUs versus gliptin. Even here, the CV hazards are favoring DPP4 when you compare in the graph. There is a 0.53 favoring DPP4. If you look at CETA and CV outcomes, the real world evidence from everything, CHD, stroke, peripheral arterial obstructive disease, or acute MIs. This is a Taiwanese study, more than 1 lakh of patients. All of them show final snapshot of CVOTs with DPP4 and SGLT2s. All the endpoints have been clearly shown here with the canvas, the declared TIMI, the MACE to be seen, CV death, non-fatal MI, non-fatal stroke, PAOD, hospitalization for heart failure. Very busy slide, but this tells you that the safety of gliptins as compared to other OADs, contraindications other than possible hypersensitivity, which is there with all patients, you don't have to worry. With metformin, you have severe renal impairment. With pioglitazone, heart failure. With SGLT2, severe renal impairment, patients on dialysis. But if you look at the warnings and precautions with all the others, and if you compare them to DPP4, yes, Saxa has a heart failure warning. Vilda has an hepatic impairment warning. Teneli has a QT prolongation problem. All the others we already went through. So the immediate intensive treatment for newly diagnosed patients may be necessary to avoid irremediable long-term risk for diabetic complications and mortality. And we have seen in studies that patients with newly diagnosed diabetes and 10 years of survival, if the HbA1c crosses more than 6.5 for a significant period of time after diagnosis, the outcomes are not good. Coming back to my initial quote, age as a consideration, question for yourself when you encounter the patient. Is age a key consideration for this patient? He's young, he needs special attention, he needs to live a long event-free life. needs to avoid all those complications, and it should have minimal impact on his work-life balance. The elderly are frail. They have a risk of tight control. You have to bring up their A1Cs, normal values much higher. Look at their comorbidities, their renal status, and the safety of drugs. Different approaches, use your best judgment based on evidence. With this, I leave you. The first slide, which I had shown, probably shows you everything. That age, that's the one. A trail for the elderly and a track for the young. Thank you, Dr. Bansi and his lovely team. And thank you for inviting me to this lovely conference. Thank you for your attention.
So this is a poll question again. Do you think we require different target therapies in the elderly and the young? Yes, the poll question result was yes, actually, we require a different therapies and target also for different age groups. And it was a really wonderful and useful presentation by our very learned speaker, Dr. Hemant Thaker, sir.